Hey, Frog Prince Runner here, and thank you for dropping by. This will be quite an angry video, as we look at all the false propaganda from a website called DailyExpose. I came across this site first when it was kept getting referred by all the anti-vaxxers and COVID denier on Twitter. So this is a site that I'll be keep on visiting and debunking all the lies. Title of the article in question is Fact: Deaths due to the COVID vaccines in the UK after 6 months are 407% higher than deaths due to all other vaccines combined in the past 11 years. The gall of these people calling this a fact, but I digress. Now, I like math. At the same time, I do understand how the numbers can be manipulated to push a particular agenda, especially when the comparison is purposefully invalid. For an example, you may hear someone comparing number of votes received by Trump is a lot higher than number of votes by Lincoln. For actual numbers, in 1860, Lincoln got 1,865,908 votes, where in 2016, Donald Trump received 62,984,828 votes. Now, can we all see what the problem is if we do a direct comparison between the numbers? I'll give you a couple of hints. There is a difference in population and number of candidates. This example should make more sense later in the video. So let's look through the article first. We will go through the whole document and then analyze it, as a lot of issues would be common. The video is chaptered, so feel free to jump to the final chapter with a summary on why this article is, well, for a lack of better word, utter BS. From the article, a Freedom of Information request made to the MHRA has revealed just how deadly the COVID-19 vaccines really are. The request made by Duncan Husband on the 29th of May 2021 asked the MHRA to provide a list of all new vaccines in the UK between 2010 and 2020, and to also provide the number of deaths per vaccine per month for the same time frame. MHRA is the acronym for Medicines and Healthcare Products Regulatory Agency, the UK's regulator for medicines, medical devices, and blood components for transfusion, responsible for ensuring their safety, quality, and effectiveness. Provided data does not break down into each month as Duncan requested, but does provide an overall review over the past decade of the total number of adverse reactions and deaths, which are as follows. All these reports are up to 8th of April 2021 and reported to the MHRA with the date when it was authorized. The Pediacel vaccine to tackle diphtheria, tetanus, and pertussis was authorized on the 3rd of December 2010. So far, there have been 3,013 adverse reactions and 15 deaths. The Pneumococcal vaccine to tackle pneumonia was authorized on the 20th May 2015. There have been 8,238 adverse reactions and 38 deaths. The Rabies vaccine was authorized on the 6th of April 2017. There have been 2,387 adverse reactions and 1 death. The VIVOTIF vaccine to tackle typhoid fever was authorized on the 25th of July 2018. There have been 309 adverse reactions and 0 death. The Menjugate vaccine to tackle meningitis was authorized on the 31st of March 2015. There have been 9,980 adverse reactions and 2 deaths reported. The Anthrax vaccine was authorized on the 3rd of May 2018. There have been 294 adverse reactions and 0 deaths reported. The Hepatitis A vaccine, authorized on 24th of December 2020, there have been 848 adverse reactions and 1 death reported. The influenza vaccine, the earliest of which was granted authorization in 2013, have had 35,068 adverse reactions and 227 deaths reported. Now we get to the COVID-19 vaccines. The AstraZeneca jab has had 960 deaths among 775,940 adverse reactions reported to the MHRA Yellow Card scheme as of 30th of June 2021. In all, there have been 450 deaths among the 236,555 adverse reactions to the Pfizer mRNA vaccine reported as of the 30th June 2021. There have also been 6 deaths among the 22,191 adverse reactions to the Moderna jab and 24 deaths among the 2,690 adverse reactions reported where the brand of vaccine was not specified. Finally, they provide a summary table with the following assumptions. This means that as of 30th June 2021, the COVID-19 vaccines have caused 1,037,376 adverse reactions and 1,440 deaths. The above table shows that the number of adverse reactions to the COVID-19 vaccines reported to the MHRA, totaling 1,037,376, are 17.25 times higher than the number of adverse reactions reported to the MHRA to all the other vaccines approved since 2010. It also shows that the number of deaths due to the COVID-19 vaccines reported to the MHRA, totaling 1,440, are over 5 times higher than the number of deaths reported to the MHRA as adverse reactions to all other vaccines approved since 2010. This is a frightening figure when you consider the total number of adverse reactions and deaths for the COVID-19 vaccines have accumulated over 6 months compared to the total number of adverse reactions and deaths for all other vaccines approved since 2010 having accumulated over the past 11 years. Then they ask, do you need any more evidence? The rollout of the COVID-19 vaccine should be ceased immediately. There will be a recurring problem throughout all the analyses. To explain it easier, I'll refer to a completely different subject. Around 11 years ago, my ex-girlfriend wanted to get a laser eye treatment so she wouldn't have to wear glasses. Me, a spectacle wearer myself, was interested as well, though I have been wearing one since my teen years. Back at those days, from the company provided this service, mentioned that there was a risk factor of permanent damage of around 0.1%. Obviously, that risk factor is much lower nowadays after the advancement of the technology. But for this example, let's roll with 0.1%. So suppose only 100 people decide to take this surgery. Mathematically, 0.1% would have permanent damage. If 10,000 people went for it, it would be 10 people. For 1 million people, it would be 1,000. This is simply a linear progression. The higher number of people going for the surgery, the higher would be the number of people with permanent damage. With that simple concept out of the way, the first vaccine is Pediacel vaccine, also known as 5-in-1 vaccine. This was used in the UK for many years. In late September 2017, the UK replaced it with a 6-in-1 vaccine for all babies born on or after 1st of August 2017. Both vaccines gave protections against diphtheria, tetanus, whooping cough, polio, and HIV disease. It was given at 2, 3, and 4 months in the UK. To understand the demography, this vaccine is only given to newborn. This report does not contain the total number of babies these vaccines were administered to. It should also be pointed out that vaccines offered throughout the National Immunization Programme in the UK are not mandatory, meaning we can't even add up all the numbers of live births in UK. Not to mention that unfortunate mortality rate. In 2019, this rate was 3.7 deaths per 1,000 live birds. Basically, what it boils down to is, without knowing these figures, one can't reliably calculate the fatality in a comparable scale. Next is the pneumococcal vaccine. There are two types, PCV, that is used to vaccinate children under 2 years old, and PPV, given to people aged 65 and over, and people at high risk because they have long-term health conditions. In UK, there are 4 groups of people who are advised to get vaccinated against pneumococcal infections: babies, people aged 65 and over, anyone from the ages of 2 to 64 with a health condition that increases their risk of pneumococcal infection, and finally anyone at occupational risk such as welders. But the report in question is actually for PPV and not for PCV. So here we are talking about the demography I already mentioned, excluding the babies. Next in list is rabies vaccine. This is recommended for those who are traveling. Basically meaning you should consider being vaccinated against rabies if you're traveling to an area of the world where rabies is common and you plan to stay for a month or more, or there is unlikely to be quick access to appropriate medical care, or you plan to do activities that could put you at risk of exposure to animals with rabies, such as running or cycling. Also for people at risk through their work, such as people who regularly handle bats, people who handle imported animals such as workers at animal quarantine centers, and laboratory workers who handle rabies sample. Once again, no data of total number of people administered to. All I can say is, in all the countries I have had the pleasure to visit, from China to Canada, I never took a rabies vaccine. And I'd also be surprised if Brits traveling throughout Europe before we decided to kick ourselves out of EU ever took the vaccine either. But again, without an actual number, we can't reliably draw a comparable figure. Next is VIVOTIF vaccine to tackle typhoid. It is strongly recommended if you're going to be staying or working with local people in high-risk areas like the Indian subcontinent, Africa, South and Southeast Asia, and South America, or if you're going to be staying for prolonged periods in areas where sanitization and food hygiene are likely to be poor. Then the Menjugate vaccine. This is offered to all babies at the age of 1 year as part of NHS vaccine schedule. Additional point to note here is the data is actually from MenC vaccine. That was in the routine UK immunization schedule from 1999 until July 2016. The single MenC dose given at 3 months was dropped from the schedule. This is because level of MenC disease were now so low that babies under 1 year of age were well protected by herd immunity. Then we have Anthrax vaccine. CDC recommends this vaccine for certain laboratory workers who work with anthrax, some people who handle animals or animal products, such as veterinarians who handle infected animals, and certain US military personnel. In UK, it is mostly recommended for military police, though only on a voluntary basis, especially during 1991 Gulf War and 2003 Iraq War. This vaccine is not typically available for the general public. Next is Hepatitis A vaccine. NHS usually advises the following group for this vaccine: close contacts of someone with Hepatitis A, people planning to travel to or live in parts of the world where Hepatitis A is widespread, particularly if sanitation and food hygiene are expected to be poor, people with any type of long-term liver disease, men who have sex with other men, people who inject illegal drugs, and people who may be exposed to Hepatitis A through their job. Finally, flu vaccine. This is given to people who are 50 and over, have certain health conditions, are pregnant, are in long-stay residential care, receive a carer's allowance, or are the main carer for an older or disabled person who may be at risk if you get sick, live with someone who's at high risk from coronavirus, and frontline health or social care workers. To recap what we understand so far, pentavalent vaccine and Menjugate vaccines are for newborn, PPV given to people aged 65 and over and people at high risk, Rabies vaccine, VIVOTIF and Hepatitis A vaccine is recommended for those who are traveling, people at risk through their work, Anthrax vaccine recommended for military personnel, and flu vaccine are for 50 and over, have certain health conditions, pregnant, care worker, and someone who's at high risk from coronavirus. We see all the vaccines so far are for a lot of different demography and covering different span of time. With all these different data points, it is an ingenious way to sum up all the values to establish a talking point. This is mathematically dishonest, to say the least. Now let's look at the elephant in the room. Under COVID-19 mRNA Pfizer-BioNTech vaccine, we see an earliest reaction date of 13th of April 1968. For AstraZeneca vaccine, this is even an earliest reaction date of 3rd of February 1921. For COVID-19 Moderna virus, this date is 15th of October 1958. What the hell is going on here? COVID vaccine didn't exist in 1921, did it? But first, there is an important paragraph that this report contains. A report of a suspected ADR to the yellow card scheme does not necessarily mean that it was caused by the vaccine, only that the reporter has a suspicion it may have. Underlying or previously undiagnosed illness unrelated to vaccination can also be factors in such reports. The relative number and nature of reports should therefore not be used to compare the safety of different vaccines. This will make a lot more sense now, as one Twitter user apparently sent an email to MHRA to get an explanation on what this earliest reaction date means. This is the reply we got. Users of the yellow card scheme are able to add the date on which their suspected reaction began when reporting to us. Due to the nature of yellow card reporting, user error can be a factor, as is the case with this particular issue. Apologies for any confusion that may have caused. However, we are working hard to ensure our online reporting tool is as easy as possible for users, and we are trying to rectify any errors in the data received as soon as possible. I did, however, find a summary of yellow card reporting PDF in MHRA website. Link is in the description. This document reads, at the time of the report, over 129,618 people across the UK have died within 28 days of a positive test for coronavirus. Part of our monitoring rule includes reviewing reports of suspected side effects. Any member of the public or health professional can submit suspected side effects through the yellow card scheme. The nature of yellow card reporting means the reported events are not always proven side effects. Some events may have happened anyway, regardless of vaccination. This is particularly the case where millions of people are vaccinated, and especially when vaccines are given to the most elderly people and people who have underlying illness. It is important to note that yellow card data cannot be used to derive side effect rates or compare the safety profile of COVID-19 vaccinations, as many factors can influence ADR reporting. Finally, the conclusion being, vaccination is the single most effective way to reduce deaths and severe illness from COVID-19. Our national immunization campaign has been underway since early December 2020. In clinical trials, the Pfizer-BioNTech vaccine, COVID-19 vaccine AstraZeneca, and COVID-19 vaccine Moderna have demonstrated very high level of protection against symptomatic infections. Data is now available on the impact of the vaccination campaigns in reducing infections and illness in the UK. All vaccines and medicines have some side effects. These side effects need to be continuously balanced against the expected benefits in preventing illness. Following widespread use of these vaccines across the UK, the vast majority of suspected adverse reactions reported so far confirms the safety profile seen in the clinical trials. Most reports relate to the injection site reactions, sore arm for example, and generalized symptoms such as a flu-like illness, headache, chills, fatigue, nausea, fever, dizziness, weakness, aching muscles, and rapid heartbeat. Generally, these reactions are not associated with more serious illness and likely reflect an expected normal immune response to the vaccines. I have also added a link to the PHE monitoring of the effectiveness of COVID-19 vaccination with actual studies and peer-reviewed data, where we see the data and reduced value for both infection and mortality. Back to the final table. We understand that we can't just sum up all these numbers. We can confirm that these data are not accurate, especially as it's based on a suspicion the reporter may have and not verified. Even going with all these invalid values, the table says the rest of the vaccines have 284 deaths out of 60,137 adverse reaction. As we don't know the total administrated value, we can only these two values and come up with 0.47% mortality rate from adverse reaction. Now for COVID vaccines. We know that COVID has higher risk factors, especially for elderly people. Until 7th of August 2021, around 47 million in UK had their first shot and 39 million had both shots. 1 million adverse reaction from this table is a complete statistical anomaly from all the actual case studies and test phases. MHRA does explain that a lot of reports are from soreness, from the injection site and so on, which I'm not sure if qualifies as an adverse reaction. On top, a lot of the deaths reported are not guaranteed to be due to the vaccine either. But still rolling with these numbers, we have 0.13% mortality rate from adverse reaction. So going with invalid data, COVID vaccine has lower mortality rate than the other vaccines. So even mathematically, the title is completely false. It is actually 0.34% less than the other vaccines combined. Again, this is incorrect because of incorrect data. But even then, it doesn't align with their scaremongering view. Well, that's all for this video. If you think it is a worthwhile video to share, and to ensure YouTube do suggest it, please leave a like, comment, and even share it around. If you want to be super awesome, please consider subscribing so you can be updated with my new contents. Let me know what you guys think in the comment section below. As always, your comments are greatly appreciated. Thank you so much for watching. Wherever you are, have a safe day. Signing off.